I'm Dr. Peter Saunders from the ICMDA, and I'm delighted to be with you virtually this morning to talk about the subject of healthcare mission opportunities in a post-COVID world. And I think this is particularly relevant for East Asia because this is the East Asian century of mission. This is where all the opportunities are today. And East Asia has been spared, I think, largely by God from this disaster in order to engage in mission coming. Now, if we look back to February, there was an announcement from the World Health Organization, the WHO, of the 10 biggest global threats of the decade. 17th of February this year, look at that date. And if you look at these on the right, 2020, they had preparing for epidemics as number 6, and the year before a global influenza pandemic, but no one had anticipated coronavirus and the changes that this has brought to us. And of course, we're living in this reality now. And before we start, we have to remind ourselves that it is God who is sovereign. He is in control of everything, of the rise and fall in governments, the decisions of political leaders, of infectious diseases, of the development of vaccines and medical treatments, of our lives and deaths. He determines the day of our lives and deaths. And we must begin by remembering that. And COVID has not changed these really important things. Man's need of the gospel, the Great Commission, the certain growth of God's kingdom, because the gates of hell will not prevail against it until all is completed. The call to us as doctors and dentists to preach and to heal, the reality of the return of Christ, the certainty of judgment, and the new heaven and the new earth. God is sovereign, and COVID has not changed any of these things. This is all part of God's plan. And Jesus, when he talked to his disciples at on the Mount of Olives, he warned them of the things that would accompany the last days, from the time of his resurrection until the time of his second coming. And pestilences or diseases was one of those things. So none of this should surprise us or alarm us. God is in control and he's working his plans out. And the question is what we do in this context. And in this talk, I want to look at these 4 areas. Where are we now? How will it impact economics and healthcare? How is it already impacting them? Where were we before COVID? That's very important to know, both in terms of the Great Commission and also healthcare. And then finally, having built that framework, what are the implications for healthcare mission? And I'm going to go through this quite quickly, but all the slides will be available to you in PDF format afterwards. So you don't need to take notes from this unless you want to. So where are we now? Well, we see a continued steady spread of the virus, different patterns in different countries. We're still very, very early in the course of the disease. Now let's look at that. This is yesterday from Johns Hopkins University, 19 million cases. We know that's a gross underestimate, and 715,000 deaths so far. And the numbers keep going up and up, and you can see almost every part of the world is now touched. If we look at the daily new cases on a global level, we see that after an initial sharp rise, there's now a continued further sharp rise up to nearly 300,000 a day, and deaths per day are now averaging on weekdays about 6,000 deaths per day around the world. The pattern in different countries is different. In New Zealand, where I come from originally, they're completely on top of it, top left-hand corner there. In India, we're seeing an increasing, almost exponential rise of cases. In the United States, there was an initial surge, a gradual tail off, but now another rise as it spreads throughout the country. And in countries like Spain, after initially being overwhelmed and then seemingly in control of it, they're now seeing a second surge coming through. So the pattern is different in every country, depending on the decisions that have been made primarily by leaders about how to deal with this. These are the figures showing the countries ordered by the total number of deaths. So it's USA, Brazil, Mexico, and UK are now the top 4. And you'll see that the number of cases for the UK, Italy, and France and Spain are much less than for USA, Brazil, and India. We know that is because they haven't been tested properly or counted properly. The UK doesn't know where it is in terms of number recovered or active cases. Spain, Netherlands are in the same situation. And the UK and Belgium are the countries with the highest number of deaths per million population, and that's probably the best measure. Africa is still largely untouched. You can see this grey pillar here refers to South Africa, and half of all the million cases in Africa are in South Africa, but we can expect it to spread over the coming weeks and months. So Africa is lagging the rest of the world. The best measure of where we are at is zero prevalence. And the Lancet has just this week launched a dashboard tracker to show us how many people are showing antibodies for the disease. This is the interactive page, and you can see in Brazil, the zero prevalence is less than 1%. And most countries that have been hit hard by coronavirus have only a 5% maximum zero prevalence, which means 19 out of 20 people have not yet been exposed to the disease, which means we are very much still at the very early stage of this. Total deaths, the US, Brazil, Mexico, and India are the fast rising ones. Deaths per million people, which is the best measure of severity, it's Belgium and the UK still who lead on that. We know the majority of infections are mild, but it's these critical cases, the 5% where the deaths come from, half of those will eventually die. We know that those aged 60 and over are most at risk, and that also pre-existing conditions like cardiovascular disease and diabetes, chronic respiratory disease, are risk factors. And those who have 2 or more of these conditions are much more likely to succumb to this disease. Men, twice the risk of women, and ethnicity, it's blacks, and then Pakistani, Bangladeshi next, other ethnicities below, Chinese right down here. So we're seeing many differences in susceptibility because of these factors. How contagious and deadly is it? Well, it's somewhere in this box here, along with the Spanish flu, which killed 50 million people at the beginning of last century. Much less toxic than Ebola or bird flu or MERS, much less infectious than measles or chickenpox, but nonetheless very significant. And imagine if this had the mortality of Ebola and the infectiousness of chickenpox, what sort of situation we'd be in. You can see the number of deaths per day worldwide. It's now among infectious diseases. It has now passed TB. This was last updated in July. So it is the biggest killer of infectious diseases now. Where are we at with vaccines? 159 trials going on, but only 7 of these have reached phase 3 and no vaccines have yet been approved for it. We wait and see. In terms of treatments, we know that the 4 effective and proven treatments are dexamethasone and remdesivir, which will improve mortality for some people, and also ventilation, of course, and prone positioning. But not much else works, and there is no cure, no vaccine, no cure, steady growth. So this is where we're at. We have been very effective around the world at slowing the spread of this virus, but we've seen 700,000 deaths in 6 months, and in current rates, it'll be 1 million by late September and 2 million by March next year if those rates continue. And the zero prevalence, that's the key thing, is still very low, just less than 5% in heavily infected countries, let alone those that haven't been touched. We don't know the case fatality rate exactly. It may well be around 1%. If it is, and then we can work out on the population that the potential death toll could be as high as this number here if there's no vaccine or curative treatment and we don't manage to control it. So this is a very serious disease. And in fact, if we look at the worst plagues in world history, we see that it's right up there with many on this page. like the Asian flu and Hong Kong flu, which killed 2 and 1 million people respectively. It's still got a long way to reach the Spanish flu and the HIV epidemic of this last century, and of course the most serious one of all, which was the Black Death of the 14th century. So this is a very serious disease, and we're still in the very, very early stages of it. Remember, HIV has been with us now for almost 40 years and has killed 32 million people. So how's it going to impact economies and healthcare? Well, there's huge uncertainty, and an article by Andy Crouch asked this question: is this a storm which will be over in a few weeks, or a winter which will take a few months, or is it more of a mini ice age which could be with us for several years? And it's now looking as though this is a mini ice age that will be with us for years, and it's going to shape our future. The impact economically of lockdown has been phenomenal. This shows the 35% drop in the world stock markets, which happened in February, March this year. And now the majority of countries are on the brink of recession. The first quarter figures, many countries red or brown, 5% or more recession or shrinking of GDP over the first quarter of this year. Huge drop in commerce. So this shows the drop in footfall, the number of shoppers in various countries, mainly first world countries, up to 80% in Mexico. And as you would expect, there's been massive increases in unemployment. The United States from just under 4% to 10%, and all of these other countries showing big increases in unemployment. In Western countries, workers have been furloughed. You can see up to 41% in France, which means that the government has paid their wages for a number of months and borrowed to do so, but can no longer do it. But of course, in most developing countries, this is not a possibility. And this has meant these mitigating measures have meant that the whole world has moved into more and more debt. And in fact, in the blue countries, which are the developed countries, we're at the level of debt to GDP ratio that we were at the end of the Second World War. So the highest ever in history, and yet it's in peacetime. In emerging economies, it is the highest debt ever in history that we're now at. Some places have done well, of course, pharmaceutical companies, but particularly precious metals. These are the gold prices and the silver prices over the last 1 year, and the pandemic hit here in February and here, this initial fall. And this tells you of the huge anxiety there is in the markets, with people not knowing where to put their money and moving it into precious metals. Let's move now to healthcare. This is the Lancet's view that the pandemic is dismantling the foundations for protecting and advancing health. Global health has entered a period of rapid reversal, and de-development is the new norm. Now, we won't be able to go into great detail on any of these, and I'm just giving you an overview of some of the things that are happening here. Extreme poverty, hunger and famine, mental health, family breakdown, crucial medicines and immunizations not being available. This is the path of those in extreme poverty, from 700 million in 2015, expected to be just 580 million next year. But these are the estimates of where the number in extreme poverty is going to go, made in April, then June, and then at the end of June. The figures are frightening. Another 71 million people into extreme poverty, 265 million people, largely in developing countries, will face starvation by the end of this year. And This shows the surge in non-COVID mortality. So we get the surge initially, the pink line of the COVID cases, but following this is the green wave of non-urgent, non-COVID conditions not being treated. And then interrupted care of chronic conditions, the blue wave. And then the red wave is psychological trauma, mental illness, economic injury, and burnout. So the collateral effects have been huge. The effect on immunizations, where it's been estimated that more children will die from missed vaccinations than the total number of people dying from COVID. The impact of the rise of the anti-vax lobby, particularly in the Western world, in the US, where half of parents only would give a vaccine to their children if it was developed. The impact on HIV, TB, and malaria, 1.4 million extra deaths are being predicted there, and you can see the percentages by which HIV and TB and malaria will rise. Non-communicable diseases, or NCDs, which kill 40 million people a year at the moment, 70% of all deaths globally, and you can see the increases there for the disruption of treatment for hypertension, diabetes, cancer, and cardiovascular emergencies. COVID, we know, is not just a respiratory disease. It produces a whole lot of other effects as well, including brain fog, COVID chest, chronic fatigue syndrome. We're still learning about this. The impact of cancer from the failure of referrals fall by 60% in the UK in just 1 month. 2.5 million in the UK in backlog for screening tests or treatment, and delayed diagnosis will of course lead to more deaths. Impact on childbirth, because mothers are presenting late for delivery, not having adequate antenatal care because the hospitals are standing by for COVID, and the greater risk of complications that result. The impact on domestic violence from families being locked down together, particularly in developing countries. Some frightening statistics there. 15 million cases of gender-based violence predicted in every 3 months of lockdown. On women and girls, the dropout from schools, with girls particularly who are disadvantaged in obtaining information, failing access to contraception, gender-based violence. And just imagine what the impact is going to be on the SDGs, the Sustainable Development Goals, where progress has actually been so good. So these are the economic and the health-related effects. Where were we before COVID? And I think it's very important to remind ourselves where we were, particularly with regard to the Great Commission, first of all, and then with regard to healthcare, before we ask the question about what are the implications for Christian healthcare mission. Jesus said the gospel would be preached in the whole world, and then the end will come. So that was one of the signs of his second coming, was the spread of the gospel. And if we look at the world today, this is a map showing the number of millions of Christian believers in every continent. And you can see that the greatest numbers are in Latin America and Africa, although some of the greatest growth is currently in Asia. But 33% of the global population now identify with a Christian worldview. These are the Christian populations showing the countries with the highest numbers of Christians. And of course, China is there, although the percentage of Christians in China is still low. This shows the percentage of Christians, people who call themselves believers, in each country. The darker the blue, the higher the percentage. And you'll see that this area here across north of Africa and Asia, what we know as the 1040 window, is where most of the unreached people of the world remain. So there is still much work to be done, but the growth of Christianity in these areas is phenomenal. This is the growth of Christianity in Africa in the last 120 years, from 8 million Christians to 633 million Christian believers. And in China, you know the story. The red line is the growth of the Communist Party, and the Christians in China are now outnumbering the Communist Party, which I'm sure is part of the reason for the clampdown on Christians meeting together. But there may well be 100 million Christians in China. People often take a negative view of advances in health, and we hear so much criticism of medical care. But in actual fact, the data shows that we've made phenomenal strides in the last 20 years or so. This book, Factfulness by Hans Rosling, I would recommend to you. 10 reasons we're wrong about the world and why things are better than you think. So let's just think about where we were at before COVID. And these are all the areas, or just some of them really, where health indices and influences are getting better. You can read that list: clean water and immunization, child cancer survival, HIV, smallpox, hunger, and so on, democracy, harvest yields, and there are the graphs. Absolutely phenomenal that you can see children dying 44% in 1800 down to just 4% now. So all over the world, we are seeing improvements in all of these health indices out of healthcare, which came largely from a Christian legacy. This is the share of the world population living in extreme poverty, which has fallen from 40% down to just 5% by the year 2030. Similarly, for child mortality, from 12 million deaths in 1990 down to just 6 million now, less than 6 million now. And this means that the cause of deaths in the world have changed because people are living longer, and the top 10 global causes of deaths now looks like the Western world just 30 or 40 years ago. So it's ischemic heart disease, stroke, chronic obstructive pulmonary disease, and cancer that you can see there. And these are, of course, lifestyle-related conditions related to tobacco, physical inactivity, excess alcohol, and unhealthy eating. So we're dealing with a very different set of diseases going into the future. These are the major causes of disability leading to days lost from work. And you'll see that here, mental health disorders particularly are very prominent. The number one, depression, then bipolar disorder, number 6, then schizophrenia and obsessive compulsive disorder. Surgical needs, 143 million additional surgical procedures are needed in countries. So we're having a bit of a challenge here with my screen. I'll just come back to that slide. So there's a massive need still for surgery, particularly in the developing world. Most of the world does not have primary health care, and yet 89 to 90% of people's health needs can be covered by primary health care. So a huge need for training. We've mentioned mental disorders already, 14% of the global burden of disease altogether. And if we look at expenditure on health, that is the major determinant of health around the world. So these countries in sub-Saharan Africa and in South Asia spend the least on health, and they have the poorest health as a consequence. The healthiest countries in the world, by all measures, are the ones shown in this slide. So Japan, North America, Europe, and Australasia. The accessibility of healthcare, the red countries are where it is poor, the green countries where it is best, where you can get to see the doctor. This is the maternal mortality ratio, highest in Africa and South Asia. The child mortality ratio, similarly, worse in sub-Saharan Africa. So that's where the need is. So here's the most important question, really, that we're addressing today. And that is, what are the implications for healthcare mission? What's going to be more difficult now going forward? What healthcare mission approaches need reviewing? What's going to be easier? What new opportunities are there for us? And what therefore should be our key priorities? And I think we need to think really hard as Christians about the shape of this world that we're now living in and how we can best spend the resources that God has gifted us with, both in terms of our financial resources and our resources of equipment, and also, most importantly, of the training that we've been able to have by virtue of the privileges that we have had, whether it's in East Asia or North America or Western Europe in particular. What are the implications for healthcare mission? I was on a conference call with some staff from the USAID in the US a few months ago, and they were talking about the West African Ebola crisis and the mistakes they had made. And this is what they said, in effect: we thought in disease silos rather than in terms of comprehensive healthcare. So they were thinking about TB or HIV or whatever, but not thinking about comprehensive healthcare. We did it all by ourselves. We failed to build any lasting infrastructure. We didn't invest in training, and we left them vulnerable to the same thing happening all over again. So the picture is of these people parachuting in to carry out a rescue, but not making any lasting change in society. And this is what we've got to be different about in future. There are many things that are going to be more difficult. It's going to be harder to cross borders, to obtain visas. Air travel may well be less frequent and more expensive. Getting into lower or middle income countries, LMICs, without a professional qualification is going to be much more difficult. And so there will be doors closed to cross-cultural pastors, evangelists and church planters, but open to professionals like doctors and dentists. It might be the end of large residential conferences and meetings. Short-term visits are going to be more difficult with quarantine and isolation. I can't go back to my own country of New Zealand without being put into isolation for 2 weeks. Raising funds for healthcare mission in the West may be more difficult because of the impacts on the economy and the stock market. And supporting full-time missionaries from the West or other places working in lower and middle income countries is therefore going to be much, much more. So we need to be aware of these doors that are being closed in God's providence and think about which doors are opening. These are some of the past mission approaches which have been very successful, but will never again meet the needs on their own because the needs are so much greater and the time is short. So there is still a role for these things, but they are not going to meet the needs on their own, either the gospel needs or the health needs as we go out to preach and to heal. So Western is doing short-term mission trips to provide direct care. International mission societies doing the healthcare work, which they've done wonderfully in the past, have just not the capacity. Church and mission hospitals cannot rely on expatriate personnel from elsewhere, and we can't have overtrained people running frontline community health and mobile clinics. It needs to be the person least qualified but adequately trained who does the job, with specialists focusing on what only they can do. I think we're going to see less of full-time Western workers supported by home churches, and there'll probably be less in the way of drugs and equipment coming from the West as well, even though the West still has extraordinary wealth. So these are some of the things that have been very important in the past are going to be less important in the future. The thing that COVID does is it speeds up every trend, and these beginnings of trends in healthcare mission are going to be sped up. We're moving from a colonial West to the rest model to a from everywhere to everywhere model. Everyone involved in mission mixing all over the world, from curative hospital to preventive community-centered models. from paternalism, doing things for and to people, to partnership, doing them with people. From full-time church planters and pastors and evangelists to tent makers who support themselves. From university-trained professionals to lay workers. From pioneering in new areas to working within secular systems. These are some of the trends that are going to be sped up hugely. And so in the final part of this talk, I want to concentrate on some strategic priorities for healthcare mission. And I'll go through these quickly, but illustrate them with examples of good practice that we can all learn from. So teaching and training Indigenous health professionals, bivocational tent makers, so people who are both doing the work of the word and the work of their medicine or dentistry, working for secular NGOs, businesses and government institutions. These are doors God is opening wide. Starting and strengthening movements of national Christian doctors and dentists. That's the work of ICMDA, because these are the best people who already have the language and culture to make an impact in their countries. All they need is the training and the support. Building partnerships with national Christian healthcare associations, which are increasingly taking over the hospitals from church and mission, from mission societies, and incredibly important training and evangelism and discipleship for healthcare workers. In the COVID crisis, it has only been healthcare professionals who've been able to get to people in their moments of greatest need. They're the only ones who've been able to be there for them, and so they need to be effective in sharing the gospel. This is the principle, of course, from East Asia. Give a man a fish and you feed him for a day. Teach a man how to fish and you feed him for a lifetime. So we need to move from direct handouts and charity to training and development of people to be able to do the job in their own context. Here are some of the wonderful teaching and training opportunities there are at the moment, and I'll go through and look at these. Pyongyang University of Science and Technology in North Korea. In this communist closed country, you can get in as a doctor or a dentist and teach university students in a university built on the place where one of the first churches in North Korea was. God's opened a door through medicine and dentistry. The Pan-African Academy of Christian Surgeons has now trained 100 African surgeons to US board certified level in about 15 hospitals in 10 countries. All of them are still working in Africa, serving their people. This is the way ahead. Distance education and blended learnings using virtual classrooms, online lectures, webinars, online training. And the ICMDA is involved in a collaboration with Christian Medical College of Vellore in India to provide a 2-year blended family medicine course, which we launched right in the middle of COVID in April this year. This is what's involved, some of the components of distance medical education, so self-learning modules and assessments, objective examinations, skills laboratories, simulation technologies, contact sessions for people, perhaps 1 week a year, but done increasingly from a distance. And it means that education will be increasingly democratized and available for all at very little cost, where a small group of teachers can potentially produce all the learning material that's needed for a whole country. So this is going to make the training of vast numbers of doctors, nurses, and dentists and other health professionals possible for less cost going into the future. We need to be up with these trends. This is our own diploma of family medicine, which we launched this year at the beginning of May with 32 students from 15 countries, mainly throughout Africa and South Asia. And you can see the component of it. Of course, none of them can afford to pay. And this is one of the contributions that those of us in more wealthy countries can make towards training people and providing scholarships for talented people who don't have the resources. CHWs, or community health workers. This is Vellore India's community lay leaders training course where they've trained thousands of lay workers, pastors, evangelists, church planters, ordinary church people in a one-year course in primary health care, being able to deliver it in villages and being in contact through technology with doctors and nurses with more experience. Teach to Transform is a US charity run by doctors, which takes groups of young doctors, you can see here, from sub-Saharan Africa, and uses them to train ordinary lay people in basic healthcare delivery, and so hugely multiplying the number of healthcare workers that are there. Partners in International Medical Education is a UK group of Christian doctors, largely family physicians, who travel all around the world delivering healthcare education to doctors who require it that they've never gained at medical school. And Prime, of course, is now looking at its future and wondering how it works in this new way. But there are many opportunities for Prime doctors through technology. One of the things that ICMDA did during the crisis was to launch our webinar series. We've now run 18 webinars by specialists on all aspects of COVID. You can see them on our website and YouTube channel, where you can watch them again. And we've had an average attendance of 200 people from 40 to 50 countries coming to each one of these. And these will be available going into the future. So it will be possible for people all over the world to hear the very best experts on whatever issue it is, Christian or medical. Tent making. This follows the example of the Apostle Paul, who made tents to support his ministry with his friends Priscilla and Aquila. It provides entry into most countries of the world, even those with restricted access in places like the Middle East. You can build relationships. You can conserve mission funds for ministries that must have full support, and it multiplies our mission personnel without great increase in costs. It's the way that the apostles in the early church did it, and it enables the gospel and Christians to penetrate into those areas of the 1040 window. These are some of the opportunities now for medical tent makers. You can see I won't go through that list, but just illustrating some of them. This is our METNA region, Middle East, Turkey, North Africa, and you can see that most of these countries do not have established groups of Christian doctors and dentists, just individuals or no contact at all. These are the sorts of places where tent makers are needed. Scatter Global is a Christian ministry which puts Christians into closed countries as professionals. Wonderful ministry. Tent International is doing the same thing. They're wanting more and more doctors and dentists who will go into jobs in places where the gospel has never penetrated and who will be welcomed because of their medical skill. And it's not difficult at all to find jobs through a whole host of secular agencies like Western Recruitment and Personal Recruitment and Consultancy Service, Ash International here, who are offering medical recruitment to the Middle East. And this is the future in terms of closed countries in the Middle East and North Africa. This is the way God is bringing the gospel into these places. We have 45 field workers in ICMDA who work with students and national movements around the world. All of them are tent makers. We could not have any of them if we had to pay them salaries. We simply couldn't afford to, but we've been able to multiply our mission force because these people all provide their own support through their work and then do their Christian mission work on top of that. This is the path of the future. Every person in the church is a missionary. So ICMDA's aim is, or our vision is, a Christian witness through doctors and dentists in every community and in every nation. And we believe the best way of achieving that is to start and strengthen national Christian medical and dental movements. That has been our focus. And the best way of doing that is through leadership training. We've grown from just 12 bodies in 1966. We hope, by God's grace, to be 100 in 2022. And the green countries have established movements which are affiliated with ICMDA, and the orange national groups that we're now in contact with. So starting and strengthening these national movements is one of the best ways of ensuring that healthcare mission takes place through Indigenous doctors. All around the world, countries in Africa and in South Asia in particular have Christian hospital associations. You can see some of them listed here. Many of these hospitals were started by missionaries from the West initially, but now they're run almost entirely by nationals and yet largely unsupported. We need to shift our focus to working in partnership with them. ICMDA is currently involved in a program of COVID preparedness for these hospitals delivered online. I mentioned sharing the gospel and being trained to do that in a way that's sensitive and respectful and with the permission of those patients and colleagues who are listening. The Saline Partnership has brought together 10 organizations, including ICMDA, to do that. So there's our first set of strategic priorities. Here are 4 more as we lead to the close of this talk. So telemedicine, leadership training, capacity building for church and mission hospitals, and new investment strategies is how we'll finish. These are the 10 biggest technological advances for healthcare in the last 15 years. And you'll see, looking down this list, most of these things are in terms of IT technology, electronic medical records, telemedicine, telehealth, remote monitoring, and so on. These are absolutely going to change the future of medicine, not just in the West and the East of Asia, but in South Asia and the rest of the world. Balloon satellites, which float at 20 kilometers above the world and have a 50-mile radius footprint, a very cheap substitute for towers and cables now available. The whole world is going to be connected very, very quickly, and that will be wonderful for medical education, but also for telemedicine, where many conditions can be managed at home using sophisticated equipment in the hands of trained lay workers who are in contact with doctors at the end, or where patients can go and book appointments with specialists at a distance and have these carried out and all their results collated online. One of the world leaders in telemedicine is the Christian Medical College of Ludhiana in North India, which launched a program earlier this year. Leadership training, we've said, is key. These are some of the courses that we make available on video on our website. And then I mentioned also strengthening the infrastructure and equipment of hospitals. African Mission Healthcare is a US mission, which is seeking to build the capacity of 50 chosen mission hospitals in sub-Saharan Africa. They're pouring millions of pounds into creating new buildings, establishing capital equipment, and giving governance training and management training to get these hospitals up and running. A great strategic use of resources. And then finally, new investment strategies. And we've got to move away from supporting full-time Western missionaries. I'm not saying they don't have a place to play, but we've got to move to new areas of having people learning languages, raising support, involving huge amounts of money to be placed in developing countries, and rather putting our money into training schemes, scholarships and bursaries, covering expenses for tent makers and trainers, paying for hospital infrastructure and equipment, investing into IT and technology, and building national ICMDA groups and national hospital associations. This is the future, and this should be our focus going forward. So there we are, a quick rattle through the implications for healthcare mission. looking at where we're at now, how it will impact and is impacting economics and healthcare, where we were before COVID, both in terms of the Great Commission and healthcare, and what implications there are for healthcare mission going into the future. Over to you, Hernda. We've run a little bit over time, but we did start rather late because of the technical problems. Hernda, do we have any time for questions? There are a few questions that have been asked, and I'm just wondering whether I should. Okay, I'm not hearing any of you, so I will just press on in faith and answer some of these questions until you draw things to a close. So from Daniel here, sometimes I find models very alarming, especially for the future. What's for the biblical standards we serve, how we both plan in the face of the pandemic, but also give hope? Well, I think we have to start by realizing that God is absolutely sovereign and in control and will use this pandemic for his glory. And we have to use our God-given skills to plan and think strategically about how we best respond, but also do it in faith, knowing that we cannot predict the future. We know generally what's going to happen, what to expect, that Christ is coming back, that he will build his church, and be wise how we spend it in the moment. Second question, how does ICMDA work with locals for sustainable system-wise getting North-South partnership going forward? Well, I've given a couple of examples there, the COVID preparedness training that we're doing for hospitals, and also the family medicine training course over 2 years, where we have 32 students from 15 countries. And by promoting and talking about these other events. But the most of the work that we do is leadership development and training for the leaders of national Christian medical associations of doctors and dentists. Next question, we notice some countries are relapsing into coronavirus. Has the WHO taken this phenomenon into account in the statistics? Yes, I think they have. They've got close tabs on it. And we know that some of the countries that handled corona very badly, particularly in Western Europe, I'm thinking about Italy, France, Spain, the UK in particular, have not learnt all the lessons and have emerged from lockdown strategies in a way that is risking leading us back into that situation. Sharing the gospel discipleship is relational. If so much is through technology, how would it affect how the gospel is being shared? Well, I think there is a place for using technology to share the gospel. Many people have become Christian believers through radio, television stations, podcasts, and so on. But it is relational, and one-to-one relationships with patients and colleagues is the best way, sharing not just the word of God, but our lives as well, as Paul said to the Thessalonians. And so this is why our emphasis has to be on training frontline workers to be effective disciplers and evangelists. It can't be left to the professional church planters and evangelists to do the job. A family medicine diploma offered by the University of Edinburgh is similar to the ICMDA one. The question, well, we did start with Edinburgh as our partner for 4 years. We moved now to working with Loma Linda University in California, who now authenticate the qualifications, but our main partner is Christian Medical College in Vellore. So it's a similar program, but we think much better adapted for the developing world. And the University of Edinburgh is moving in a more Western-oriented direction, offering it at higher cost and requiring people to travel to Edinburgh. So we think we should be investing into this program we're using at the moment, which is much cheaper, much more accessible, and can be made more widely available, and we think is more scalable in terms of building it up more in the future. So I think I've got Hernda to the end of the questions there, and I will hand back to you because we're at 10 o'clock and I suspect that the people at the conference are keen to go on their excursion.